Hello class, my name is Lupe Vazquez and today I'm going to be talking about a CT liver 4-phase and what is included in this exam, why we do these 4 different phases, and we'll also be looking at a case study in which the physician ordered this exam for a patient. So, what is a CT liver 4-phase and when would this exam be ordered? So, a CT liver 4-phase is a CT scan of the liver including 4 phases, which are unenhanced or non-contrast, arterial, venous, and a delayed phase. And some clinical indications when this exam would be ordered is if the physician is diagnosing or evaluating new liver nodules in patients with a history of liver cirrhosis, if there's a new possible hepatocellular carcinoma, which is what HCC stands for, when evaluating hepatic metastases. It would also be ordered if the patient has elevated alpha-fetoprotein lab levels. Alpha-fetoprotein is a tumor marker test, so if this is elevated, it could be a sign of a liver tumor. It could also be ordered as a baseline scan for liver cirrhosis and following up for any kind of metastatic disease. This is particularly the chosen scan for hepatocellular carcinoma because hepatocellular carcinoma tumors are hypervascular, and so they are best seen in the arterial phase of this exam. And just a little bit more information on that. In the arterial phase, hepatocellular lesions enhance greatly, and in the venous and delayed phases, it is the opposite. The lesion will demonstrate little enhancement. So this is a pretty characteristic sign of hepatocellular carcinoma. And just for visualization purposes, I have a diagram on the right. So it's kind of just showing the 4 different phases of this study. So you can see in image A right here, this would be the non-contrast phase. Contrast has not been administered yet here. In image B, that would be the arterial phase, and you can see how brightly lit the aorta is. So that could also tell us that that is the arterial phase. In C, we have the venous phase. You can see the aorta is not as brightly lit anymore. And then lastly, in D, the delayed phase. So the aorta is the least bright in all the images in this one. So moving on, present my case study. So we have a 62-year-old male with a history of liver cirrhosis who came into the ER with the following symptoms: mild to moderate upper abdominal pain, jaundice, early satiety, history of weight loss, and development of ascites. And so the patient came into the ER after onset of very severe abdominal pain and development of ascites over the course of a few days. And the fact that the patient is showing these kinds of symptoms indicates that the disease or whatever pathology they have going on is most likely very advanced and invading the portal vein or the hepatic veins because of the development of ascites. So then we can talk about testing and diagnosis. So upon entrance to the ER, the patient had laboratory testing performed. So this included liver function labs like bilirubin, alkaline phosphatase, other labs like a complete blood count, a platelet count, and albumin, and also the tumor marker test, alpha-fetoprotein, which did come back elevated. Some more information on AFP. AFP usually isn't seen in high levels in adults. So in some patients, AFP levels are elevated if they have an underlying disease like liver cirrhosis, which our patient does. So this could, very likely be why this test came back elevated. However, since having liver cirrhosis puts the patient at a higher risk for liver cancer, I think that is the reason why these labs were still checked, because they could also signify there being a tumor in the liver. So they did come back elevated, and since those labs alone are not enough to, confirm a diagnosis, that prompted more testing. So then the physician ordered an abdominal ultrasound, which did show a lesion in the liver greater than 1 centimeter. And this was a new finding compared to the previous CT that the patient had done. So then after the ultrasound, a contrast-enhanced CT tailored for liver lesions was performed, and this was the 4-phase study. So this included the non-contrast phase, and then after that, liver images were acquired during the late arterial phase, the portal venous phase, and also in the delayed phase. And then the results of that CT displayed the hallmarks of HCC, and it's just some little more information on how that appears in the CT. And ultimately, the scan was abnormal, and so the patient was diagnosed with hepatocellular carcinoma. So what is hepatocellular carcinoma and treatment options? So HCC is a primary malignancy of the liver, occurring predominantly in males, in patients who are males who have an underlying chronic liver disease and cirrhosis. And it is a liver tumor with neoangiogenesis of arterial origin, which is why it enhances intensely in the arterial phase, and in the portal venous phase, and in the delayed phase, the tumor washes the contrast out and it becomes hypodense relative to the normal liver parenchyma. And I did list some options for treatment here. Ultimately, treatment will depend on the size and location of the tumor and how well the liver is functioning. Some options are surgery to remove the cancer and the area around it, but that's not always recommended. And sometimes it's not even an option if the patient has, a history of other liver disease. So that wouldn't be an option for our patient because he has liver cirrhosis, so he doesn't have a normal liver function. And other options for treatment include a liver transplant surgery, so taking the whole liver out, radiation therapy, chemotherapy. But ultimately, this would be something that the patient discusses with their primary care physician. Also, unfortunately, the prognosis for hepatocellular carcinoma is poor. The 5-year survival rate is 8.4%, and patients who have liver cirrhosis have even shorter survival times, and the options for treatment are more limited. So let me just talk a little bit about how hepatocellular carcinoma looks on a CT. So I do not have the actual images for our patient's CT scan, but these images are very similar to how his scan would look because we can see the liver is very enlarged and it is also cirrhotic, which is the case with our patient. And in these CT images, we can see there are plenty of small nodules all over. And we can start here with the arterial phase. So this is where the lesions would be enhancing greatly, although it's kind of hard to see in this particular image. But then we have the portal venous phase and the delayed phase. So in these phases, the lesions are demonstrating little enhancement, which is pretty characteristic to HCC. So did the patient have a biopsy or a drain, or were they admitted? And what did the radiologist suggest as to next steps for the patient? So a biopsy was not required for this patient because the lesion followed the diagnosis criteria for hepatocellular carcinoma on the CT. The patient was admitted to the hospital for a couple of days for observation and to help relieve the ascites, so they were given medications to help with that fluid accumulation. The radiologist did suggest the patient follow up with a primary care provider to discuss treatment options, and along with the primary care provider, also an oncologist, just to see how to go about treating the cancer and just what the best option for the patient is, since he has an underlying liver disease. And at this point in time, there were no delay scans to be obtained per the radiologist. So why do I think that the physician ordered a CT exam rather than any other exam? So I think that the fact that the patient had a history of liver cirrhosis, which tends to be associated with hepatocellular carcinoma, is the reason why he ordered a CT liver 4-phase. I'm going to talk a little bit about other exams that may or may not have been helpful. So with ultrasound, our patient did have this exam done first, and it was a good exam to do first because there was no radiation involved. However, ultrasound can be limited in what it can show if the liver lesions are too small. So because of that, the CT was ordered just to visualize more and to see more. An MRI could have been pursued if the findings on the CT were not diagnostic enough, but in our case, they were. So an MRI was not needed anymore. And liver biopsies is also something that the physician can choose to do. They're typically encouraged when the patient is not at high risk for HCC, and it's also encouraged in tumors that are not as advanced, but our patient was pretty advanced, so the biopsy wasn't necessary to confirm the diagnosis because the CT liver 4-phase was enough to diagnose the patient. And also with biopsies, there is a risk of false negatives. So even if it comes back negative, imaging is typically still recommended. And there can also be a risk of tumor seeding. So because of those risks, biopsies are typically not performed on patients whose imaging exams already show typical features of HCC. So ultimately, I think a CT 4-phase was the best exam for diagnosis because the specific cancer that our patient was diagnosed with has a very specific appearance on this kind of study. So I don't think another exam would have been more helpful to diagnose it. So did you use IV, oral contrast, or both? Yes, both IV and oral contrast were used. For IV contrast, what we used was ISOView 370, and that's typically used for a 4-phase liver CT. The dose of the contrast depends on the weight of the patient. So if the patient is less than 200 pounds, then 75 mLs are usually administered. If the patient is from 200 to 250 pounds, then 100 mLs are usually administered. And if the patient is more than 250 pounds, then 125 mLs are administered. If ISOView 370 is unavailable, then Omnipaque 250 can also be used as a substitute. And then looking at a protocol that I found online, oral contrast is also given, and this specific protocol gives water. So 500 mLs of water given 20 minutes before scanning, and then 250 mLs given on the scanner table immediately pre-scan. So, was it a multi-phase exam or a single phase, and are there different protocols for age if multi-phase? So this exam was a multi-phase exam, and as I mentioned before, this includes 4 phases, a non-contrast phase, a late arterial phase, a venous phase, and then a delayed phase, which could be anywhere from 5 minutes to 10 minutes, just depending on what pathology they are looking for or just on the site protocol. So in the non-contrast or non-enhancement phase, this is done before contrast is administered, and this phase can be helpful in detecting calcifications, fat in tumors, fat stranding as seen in inflammation like appendicitis or diverticulitis. The late arterial phase is done. It depends when it's done, depending if the scanner is doing bolus tracking or not. But if the scanner is doing bolus tracking, then the timing would be 15 to 20 seconds after injection, because you want to see that contrast as it is going through the patient. But if the scanner is not able to do bolus tracking, then the timing for this phase would be a little bit later, so around 40 seconds post-injection. And in this phase, all structures that get their blood supply from arteries will show optimal enhancement. In the venous phase, the timing for the venous phase is typically around 70 to 80 seconds post-injection. And then in this phase, the liver parenchyma enhances through the blood supply by the portal vein. Some enhancement of the hepatic veins should also be seen. And lastly, the delayed phase, the timing could be anywhere from 6 to 10 minutes post-injection. And this can also be called the washout phase or the equilibrium phase. And this phase shows the washout of the contrast in all abdominal structures except for fibrotic tissue. And based on my research, I did not find any information that would suggest a different protocol for different age groups. The only thing that I did come across was a different dose of contrast to be given depending on how much the patient weighs. So had the patient had prior CT exams of the same kind, any allergies? So yes, the patient had an abdomen CT before, which was what confirmed the liver cirrhosis. And after looking in the patient's chart, I saw that they did not have any allergies to contrast during this previous study. So because of that, there was no need for pre-medication for this exam. So I'll just talk a little bit about technique and scanning parameters. So this exam was performed on a multi-detector helical CT scanner. Patient prep included no solids for 3 hours prior to the examination. Patient position, supine, feet down with arms above the head. Both oral and IV contrast were given. 4 acquisitions were obtained. Coronal and sagittal reformats were done for each of the 4 phases. The KVP that we used was a little bit higher than a normal KVP, so we adjusted this scanning parameter due to the patient's ascites. But based on my research, we would have used 100 kV if the patient was below 140 pounds. 120 kV if the patient was above 140 pounds. And then in this specific case, we increased the kV a little to compensate for the ascites. And the scan field of view that we used was large. The scan range extending from 1 centimeter above the diaphragm through the lesser trochanter. No shielding was used, and we did use iterative reconstruction. The GE scanner did have an ACER setting, which was selected for the exam, and using ACER allowed us to perform the scan at a lower MA while still obtaining diagnostic images and reducing noise. So what did I learn from doing this project? So I learned that a CT liver 4-phase can be used to diagnose several different pathologies. I learned what structures enhance in the different phases, which I did not know before. I learned that there are many steps clearly that a patient has to go through in testing, and sometimes it can take a while to get a diagnosis. And this really reinforced how important it is to always be kind to patients and to do our best to provide a good patient care, because we don't know what they may be going through or how they may be feeling. For example, the patient may be stressed or anxious about getting a diagnosis, and that uncertainty of not knowing what's going to come back on the scan can be really scary. So we should always do our best to try to make them feel as comfortable as possible in any way that we can. They may also be in a lot of pain due to the testing that they're having done, especially if they're having like biopsies done or if they're having constant blood draws. Like, that's not fun. And so just ultimately we should do our best to have them be as comfortable as possible. And in researching this particular disease, I learned about the risk factors for hepatocellular carcinoma and how often it occurs in people with underlying liver disease, such as cirrhosis, Hep B, or Hep C. I also learned that, unfortunately, symptoms don't occur in the early stages of this carcinoma. They typically occur once the disease is more advanced, and this puts into perspective the importance of checking on symptoms early, because you never know what it could be and you don't want to wait until it is too late or very advanced. Overall, I learned plenty of information from doing this project, as in what steps or testing the physician usually follows to diagnose these kinds of diseases, and also what scanning parameters, protocols, what reformats we typically do for this particular study. Now I am now more knowledgeable about what the study can detect and what is involved in the different phases. So yeah, that is my presentation, and thank you guys for watching.